Thank you for the invitation from Aspetar Sports Medicine Center and also from the Groin Pain Center. And as Per said, he's giving me a very specific task. And what I've tried to do is sort of take what we in Denmark call the helicopter view on this. And maybe here you could say that I'm trying to give you an overview looking from the torch. And I'm going to talk about exercise, but a lot of the examples that I'm going to give is going to be related to the problems of introducing a treatment in this area. So there's going to be a lot of general things that I want to go through. So just to show everyone where Denmark is, so on the top of Europe there, and we are very close to the airport. So if you ever want to come and visit us, we are only 5 minutes away from the airport. We can come and pick you up. And this is where I also work. So we don't have a torch, but they're actually building at the moment. This is the Copenhagen University, and this is the medical department. It's not as high as the torch, but we can grow grass on top instead. So we hope that that will look nice. And this is how we go to work in Denmark. Very different from here. And this is what we do in the winter, still going to work on our bikes. And I just want to show that, of course, cars, we have cars in Denmark as well, and you can see as soon as cars came in, the cyclists came down. But actually now it's coming back up. So this is sort of the peak hour, how many cyclists would go through this actual spot in Denmark. You can say that the main model that we use at our research center is football or soccer. And these are two examples from two very talented footballers we have. With very serious injuries. The first one here has been out for 13 months with a hamstring injury. And this guy was out for more than a year with groin-inguinal problems. And these are our two sort of main research areas we looked at. And we've also performed RCTs in these areas. And as you can see, groin injuries, depending on what study you will pull out, but that will be the main injury, having an incidence of 1 per 1,000 hours. And you can see again 1 per 1,000 hours, or approximately 10% of your team would have groin injury if you use the time loss definition. Previous studies from Norway also showing that the risk factor for re-injury is very big if you have a previous injury for both of these injuries. So as soon as these players sort of experience a groin injury, then they'll be in big trouble. And we've just finished a study that we did last year, just to show you how the time loss definition might not be a very good summarize of what is going on. So here you can see that if you look at just 40 teams, around 700 players, half of them would say yes to the question, did you have hip and/or groin pain during the last season? And we could break that down into how long they would have this. And so some would say, well, that might just be a very small problem, but actually a third of these would have it for more than 6 weeks. So a lot of soccer players having these ongoing groin problems. We then use the Hager score, and I'm going to come back to that and show you what that is. But basically it's a score that goes from 0, which means very severe problems, to 100, which means no problems. And we could call it that in the way that if you had problems for more than 1 to 2 weeks, you would have a score like this. This is the season after, so this is the beginning of the season. So they had 1 to 2 weeks the season before. 3 to 6, they would be significantly different from this group. And if they had it more than 6 weeks, they would have a lower score starting the new season. So again, just showing that even though they might not be out with an injury, these guys are having problems. So I think when we look at groin injury incidence in the literature, we're only looking at the tip of the iceberg. So the prevalence and the really big problem, and also some of the guys we see today, they would be part of this bottom part, and they would be playing, but having ongoing problems. And this is where I work in Copenhagen, and as you probably know now, Per is head of the department and was my supervisor during my PhD. In Copenhagen, we sort of have a main approach, which is very much based on the PICO definition. So that means we're looking at different problems. This is groin injury being one of the main ones. We look at different interventions for this group, and we want to consider what kind of comparison we need for this kind of group. and then we of course measure the outcome. So this is a very simple model proposed by Sackett et al. And I will try to illustrate how that is a good starting point, but also how that can have some problems. So this is how it looks like. So we have patients coming in here with a specific problem. We introduce an intervention and very often also a comparison, and we measure the outcome. So just to show you an example of this, we probably all agree that eccentric exercise for Achilles tendinopathy is a pretty good intervention, and we also might agree that that's a diagnosis that we'd be quite happy to agree upon. And when you look at the literature, you can quality rate these studies, and you can look at different things, so you can see whether they had random allocation, whether they blinded the subjects and had adequate follow-up, and so forth. And you can actually score that, and you can say, well, this Rompe study got a better score than the other studies. But there are a few things in these kind of sort of summarizing studies that we can't really see. So one of the main challenges, I think, as we just saw today as well, is that when you want to put people in a study with groin pain, these are the different possibilities that you have. And probably the slide could be 3 times as long as this. So if you go from different country to different continent, you would have different terminology. So in Australia, they sort of coined the term osteitis pubis. In Scandinavia, they would call it adductor-related groin pain, even sportsman's hernia. In the States, that would be the pubalgia. And in England, they have a surgeon who called it after himself. And you might even meet an orthopedic surgeon who will tell you that this is all coming from the hip. And this is not sort of, I think, this is a study, a very old study and a classic study in my mind. And this is a study where they showed that what happens if you put 6 specialists in a room. And I'm not saying that that was happened today. But in this study, you had 21 male athletes, and 19 of them would have a positive diagnosis for 2 or more diseases. And you even had 3 patients who would be given 4 diagnoses. Or 4 diseases. So they come in with groin pain, and the poor guys go out with 4 diseases. So I guess it's fair to say that in this area, it's not a problem to give a second opinion. So again, consider that now it's groin pain we want to put it in this group, and we want to have an intervention group and a comparison group. So challenge number 1, that would be the diagnosis. So, and that's what we looked at today. So that would be clinical examination. It could also be diagnostic imaging, as I put here. So part of the diagnosis could be the diagnostic imaging. And as Adam very nicely illustrated yesterday, this is an area where we have to be extremely careful, because here we have the adductors coming in, and we have the rectus muscles coming in, and all the oblique abdominals coming in. So in this area, just within a few centimeters, you would have interdigitin fibers, and it's very difficult palpating these different structures from each other. So again, you should think that I've stolen Adam's slides, but I actually didn't. I've never met him before, so I just want to congratulate you on finding the right slides, Adam. And here we have the functional anatomy. And again, what Adam really nicely illustrated yesterday as well, as in kicking, you really have to consider forces going in this direction, but also in this direction and in this direction. And all these forces will meet down here, and these muscles will communicate with the adductors as well. And as I agree with Adam, this is a very nice slide where you can see all the 3 layers, and where you have abdominal muscles that go in different directions, but also form into this aponeurotic plate, and also in this conjoint tendon, which some believe is there, and some others won't say it's not. Just to show you how this becomes a problem when you look in the research, this is a study from the States where they looked at these people with groin injuries on MRI. And that's what they would find. So this is the imaging findings here. And so they would very often find rectus abdominal insertional injury. Sometimes they would find a combination, and in very few incidences, they would have adductor-only injury. And then you have some of the other diagnoses here. If we look at the entities from our study, of course, we cannot say these are the same patients, but if we assume that these patients are quite similar, then you could say that we would find that most of them would be adductor-related, we would find a lot of them being ileoceous related. And if you look at the total of other clinical entities, we actually find quite very few of those. So my point would be that this is just probably the fact or the way we define these problems. So I'm not saying that our approach is right or SOGA is right. I'm just saying it really depends on where you put your finger, but also your whole conception of what is going on in this area. So I think you really have to be aware when you look at the literature and not take the written word for granted here. Just to show an old study where they also, a very nice study, everyone who's been looking at it should read this. This is the classic, one of the first studies. And again, just showing that a lot of adductor-related problems, and also they found some rectus abdominis problems, and again, a few other problems. And again, reinforcing what we have seen in our studies, that this takes a long time. So, challenge number one still, diagnosis, and then if we move into diagnostic imaging and what we see on imaging, here are a lot of things going on. And now, the thing with this is that we don't have a lot of studies on all the tissues that we've been looking at today and yesterday. But if we look at bone and radiology, you would say that here is some pathology, and here might be some pathology. The problem with these studies also showing pathology on X-rays is that the few studies out there actually suggest that these changes at the pubic symphysis, that they are more related to the athletic activity. So the more soccer these guys were playing, the more changes they had on these X-rays. And again, showing here that increasing age was the other factor that is related to changes at the pubic symphysis. So again, we have to be really careful with some of the changes we see, because some of it might just be related to the fact that these guys are doing a lot of activity, and the other thing would be that they're actually at an increased age. So this is an asymptomatic study using asymptomatic soccer players, and here they used MRI, and this is what they found. So again, a lot of positive findings, very close pubic bone marrow edema in 23%, primary cleft, secondary cleft, and no tears. And again, look at the hip pathology, a lot of labral tears in people with no symptoms. And one of the worrying things here is that when you look at the inter-reader reliability as well, that's really poor. So these people looking at these MRIs don't agree either. So it might be one radiologist saying that there's a tear, and the other one says there's no tear. So it might be better than flipping a coin. But then if we move into still using diagnostic imaging, now we're looking at the labral lesion. And this is where two observers, again, are looking at the labral lesion. And this is how they agree, 77% of cases. Problem here is that the kappa value here, if you look at the confidence interval, now we're getting very close to flipping a coin. So this is not an easy topic, and it's something that we have to be aware of. And we have to improve our skills in diagnostic imaging, but also in the clinical examination. So the approach that we have taken for many years in Copenhagen has been to develop, and that's Per has done this and put this forward many times, reliable clinical examination procedures. So when you see the examination you saw today, the different examinators using our system would be able to do this in the same way and get the same results. We might not agree that this is the valid diagnosis, but we would agree, and this is what this study shows, that we can agree between observers and within observer. So this is sort of the formula we have put forward. So we are working with these entities, and this came up today, and this came up today, and this came up today. But it was never, and I was sitting looking at it, it was never only for this, the actual clinical entity was there when you consider the two factors that has to be present. And that was actually the comment that Bruce made as well, is that for having this entity, you need to have pain on stretching as well. So, and this is how you would define adductor-related groin pain. So you need pain on palpation at the insertion point, just where the adductors go into the bone. And you need pain on this contraction test, but at the same spot. So not just any pain, pain at the spot where you just did your palpation. And The example I'm putting forward here is that some would say, well, is this valid? It might not be, but you can still use this in a study, and we can define these people, and you would be able to reproduce this study, and we can say if we give them a standardized program, up to 80% will get better if you have an actual active training approach compared to what used to be called standardized physiotherapy back in the days where we did ultrasound, massage, and stuff like that. So just showing that even though we don't actually know what's going on, we can still try to move forward by agreeing on some of these things that we do so others can reproduce our studies. And again, just for the sake of showing that this actual program actually had results that were still present after 8 to 12 years. And in our mind, that's probably more that they have this program as an education and they now know what to do when they get this problem again. So just to emphasize the clinical examination and the diagnostic parts, I think challenge number one would be to use approaches that we can actually reproduce and maybe even agree that this is the one we use because they are the most reliable ones. Challenge number two, this is going to be when we look at exercise as a medicine component. So as Per mentioned today, he's not happy about this being called physiotherapy treatment. This is exercise being supervised by physiotherapists or other people with that kind of skills. Again, just to show you why this is important, we have other important qualities when we look at the RCTs than what I just showed you. And this nice review, they actually tried with Achilles tendons to see whether there was a dose-response relationship between how much eccentric exercise they will be getting and what the results was. The problem with that was when they looked into the study, they first realized that the programs, some of the programs were a little bit different. So they actually did a combination of the old classical Alfredson study and the other two did the Alfredson study. But the big problem was when they tried to see what was the compliance of these exercises. If you look in those studies, there's no data reported on the exercise diary. No data reported. Here there's a diary, but very limited data reported. So all these programs in these studies seem to be efficient, but still we don't know whether they actually did the program. And just to emphasize, using different scores as well, whereas this is related to specific tendon problems, and this would be more related, the FAIRS is more related to instability of the ankle or even ligament injuries. So again, going back to this rating and just making sure that the intervention, what we really have to make sure about is whether people are actually getting the intervention and the exercise as we have prescribed it. And that they are not just putting the pills, if the pills were the exercises, and they're not just putting them. So it could be the guy from Kuwait, he's not been doing his exercises for 3 years. He's been pulling it down the drain. So is this a problem? So now, again, I'm going to move to a different, because we don't have a lot of data on this on groins, because the studies have not been made. But if we look on hamstring, they tried to do a Cochrane review a few years ago, looking at whether eccentric strengthening was effective for preventing hamstring injuries. And this was what they found. So when you look at a small study from Askling, he could find an effect, but the study from Australia and the study from Norway couldn't find an effect. But when you go into those studies, Askling didn't report his compliance. You would imagine that they had good compliance because they used a very awkward machine that you just don't do by yourself, but there was no reports on it, so we don't know. If you go to the GABA study, they had 30% compliance. If you go to the Engelbrechtsen study, they had 20% compliance. So 2 studies are not working, but people haven't been doing their exercises. So I think it's very dangerous to say that this exercise is not working because no one did it. So again, this was the case, pouring tablets down the toilet. So we need to establish efficacy before we can say whether exercises are actually effective. So a very important point, and we need to do that in the groin as well. So we did the hamstring study, And we knew from Norway, where they did a really nice study, the reason why that was not in the Cochrane was because it was not a randomized study, but it was what you call a quasi-experimental, so they had a control group, and they had really good results. So we mimicked that and took out some stretching parts, so it was only hamstring, Nordic hamstring, and what we could show was that you could really reduce hamstring injuries, not just all injuries, but also recurrent injuries. And the difference from the study was that we had 90% compliance. And our results just looked like the results from Norway, so that was really reassuring that if you actually do your exercise, you actually increase your chance of getting a good result. So we are still in challenge number 2. We need to know more about interventions that could target specific pathologies in this area, because as you've seen, there are a lot of different pathologies. And what we probably also should consider, and I'm on the same line as Adam, is that there might be different mechanisms of injury that we don't really understand here. So Adam said he couldn't wrap his head around how these people were kicking with the same leg, or whether it was the standing leg, or so forth. But here, I would say this could be one injury mechanism. Looking at the adductors, we know they are stabilizers of the hip joint and from the pelvis, but as soon as your body comes this way, they have to work eccentrically to actually maintain the integrity here. The other thing is, if you then stretch your leg at the same time, you really increase the stress that goes through the adductors. And this would happen on the kicking leg, and it would happen on the non-kicking leg. This would be random and depends on the direction you have to take. If you look at kicking, you have a different possible mechanism of injury. Here you have, again, the adductors are very important kicking muscles. They work really hard eccentrically. So again, there's a lot of stress on this side, but also EMG studies show that you actually have almost the same amount on the other side. So again, that could explain why this would come up on both sides. And again, you have a lot of stress, and you can even almost see that line going across, as Adam showed yesterday, but also here. So you have a lot of stress on the whole complex. And Adam showed this picture yesterday, and you know what's going to happen. We flip it, and then we have muscular insertions by 2/3. So again, this could also be related to the mechanism of injury, so we need to understand the tissues underlying this. And this is the biomechanics of kicking, and this is the study showing that when you just do a normal instep kick, not a side-footed kick, just a normal instep kick, so you would kick with your wrist, but that actually puts a lot of stress and have peak adductor activation just as you're going to change the direction from going backwards to coming forwards. So everyone would think that at ball contact the problem would be there, but actually the forces are much greater when you change direction. And again, these are a few pictures that we borrowed from a PhD student, and this is an acute injury. And just to show again how that fluid this is an adductor acute complete tear, but also just to show that the fluid is actually connected in some way to the joint, and it also seems to travel a little bit to the other side. And this is from the top. Here you can see all the fluid from one side, but again you can also see up here that something is connected here, and there might be something on the other side. So again, if we look at the abdominals and think about a mechanism of injury, again, very nicely illustrated that you get this torsion in the whole system. And we know that these tendons are connected, and they are connected to this epidoneurotic plate. We have to consider that there are many muscle groups and synergies here. And so this was sort of the frontal system we saw yesterday, and this was the posterior system, but we also have a lateral system. And that is the gluteus medius and the adductors. As soon as you're standing on this leg, you really have to balance those muscles as well, together with all this. And there's also a system, a much deeper system, where you have the transverse abdominis, so some of the portions that could be related into the inguinal problem, but also the deep iliacus muscle here and the psoas muscle actually fusing into one big tendon as well. And again, you see the 3 layers. We need to consider different muscles with different functions. So we need to monitor the quality of exercise and the compliance for these people. So again, just mentioning the study we did. Don't have to spend much time. And this is just to give you an example of how this program was built. And so remember, this is for adductor-related groin pain. So this exercise is a starting point. So you do isometric contractions, and you define how much you're going to do, 30 seconds, 10 repetitions. And you can do that with the ball between your legs. And it's not to say that you should do this for hernia surgery, but or even without, just to say this is how we did it. And there was an exercise that becomes a little bit more functional, but now you slide out and back in. And again, we put more stress on, again, trying to keep it in a functional position. Now we're really working the adductors with the resistance bands or even with weights that we can control. And we're moving into more functional movements where we try to work on coordination and timing, and even you could say core control here, as Per just mentioned. So to give you a brief overlook of the program, we would say that we have sort of a low load period where the main aim is to isolate some of the involved structures. So that would be the adductors a lot here, facilitate them, work on strength and endurance, and even go into some kind of hypertrophy training at some point. Then you move into a period where you have more moderate load, but you go more into coordination. So you want to integrate the strength that you build up. And then at the end, you go into more sport-specific exercises where they're also allowed to run, but you do sliding and stuff from side to side. So this is just to say that this is sort of the basic recipe that I think might be an idea to use also for different entities. The thing you would have to change maybe would be this isolation part. So we're really targeting the structure that we think is injured. And again, important aspects that a lot of people forget is that you have to do a lot of repetitions. It's 3 times a week. It was supervised. They had no provoking activities. That doesn't mean they couldn't feel it, but it shouldn't make them worse the day after. And again, running allowed after 6 weeks, and we had good results. So we've now put forward just to take out, and we've done this in healthy, just to see with the elastic band, if we use a more primitive approach, can we actually induce strength changes in these people going from what is 15 repetitions maximum, so that is just the repetition you can do 15 times, and then you increase your load so you go down to so you can just do 8, and you do that over 8 weeks. 2 sessions the first 2 weeks, and then you go into 3 sessions, and you have 3 sets in each. And this is important to describe. And what we found is that when you take this to soccer players, what you can actually improve in 8 weeks is the eccentric component. And that is very nice because we know that especially the eccentric strength gives you an ability to sort of protect your muscle tendinous structures. So we could show that in the group that did the strength training with the elastic band, they would have a difference from the control group in the eccentric strength. So what we are trying to do whenever we introduce exercise, and that's why I wanted to show you the other study, even though it's only adductors, we want to make sure that we know what the load magnitude is, the number of repetitions, number of sets, rest in between sets, and so forth. So we actually describe all these things. So afterwards, we can count and see how much exercise did they get, but also so we can, when we plan the study, we can say we're going to give them this much for this phase, this much for that phase, and so forth. Because if we don't do that, again, we don't know what was being given and how much they actually did. So that would again be like giving them this bottle of pills, and some would get half a bottle, some would get a full bottle, some would get, there would only be 1 pill lying in the bottle, and they would get that one. So we need to make sure that this is the same for the patient getting exercises, or even if you want to combine exercises with surgery and just compare 2 exercises, you want to make sure that exercises and surgery is the same, and exercises alone is the same. So this is the proposal for suprainguinal exercise. And if that's in our model, they would be under the abdominal-related groin pain. And again, we remember the focus. So there was a structural focus first, a second focus on coordination, and a third focus, which would be sport-specific. Again, remembering that we probably cannot just look at the abdominals. We need to look at this integration between abdominals and adductors. Just again, remembering that some would actually say that they have both injuries, and we need to look at all these muscle groups again. So what we have done is we've looked at some of the exercises that we've been doing in the past, and we have looked at that with EMG to evaluate whether these programs, because we know that strength training is quite effective for inducing local hypertrophy, not just at the muscle, but it also actually affects the tendons. So if you want to increase the strength of that aponeurotic plate, or even the combined structures and the abdominals, we need to make sure that exercises are performed at a specific intensity. So this was in an intervention program that we did that did not work, but we actually looked at those exercises, and this is 100% of EMG activity. So that's what you would normalize to. And then you look at the different exercises. So this is a partner exercise. So here you can see they have a lot of adductor activity, and I've put some lines in. And this line, 60%, is the normal amount of EMG activity you would suspect you need to have to be sure you have hypertrophy and neuromuscular higher activation levels. But it has been suggested that even from 40%, you might get some of this effect. And I would suggest that if you have somebody who's injured, you might get away with being in this area as well. And just to show, if you then do the abductor one, so you're pushing out now, then abductors, the glute medius, activation level goes up. But again, the other muscle structures are not being affected in the same way. And when you do the folding knife, you get a lot of activities in your obliques and your rectus abdominis again. So it does matter what kind of exercise you will initiate in what kind of muscles that will be active. So we cannot just give any exercise and think we're going to target that structure. And again, if you look at the coordination exercise, again here that's not a strengthening exercise, but again, it makes sense that the glute med is the one making the most work in that situation. So a study, not from our department, but some of the guys we work with, they were doing abdominal crunches on a ball, and what they showed, they looked at the machine as well, so they compared the two, and they actually had elastic bands here, so they could make sure again that we're working at a specific intensity. And what they showed was that they could actually, with the elastic band, get very high levels in some of these important muscles. So the obliques, external obliques, right and left, and the rectus abdominis. And it was actually more effective for some of it than the crunch machine. And I think that's to do with gravity. So as soon as you lie on a ball, you'll be working up straight against gravity. If you then use elastic bands, you will increase that even further. And we looked at that as well. So we took the elastic bands off, but again on a ball. And what we could show, we tried to compare that to the folding knife that we've been used previously. And again, we could show that if you really target it on a ball, make sure that they're stabilized at the feet, and you then just use the lever, so how far they're over the ball, then you can actually get 10 RM without an elastic band, and you can get very high activation levels in some of those muscles that we really want to condition and that we think has been weakened by the injury, or even before the injury, by all this kicking and rotation. The two differences between these exercises is that when you do the folding knife, you would go from here to here. And as soon as you go on the ball, you go from here to here. So here you can actually start initiating some of that rotation and extension that you also get when you're kicking. So I would suggest that this becomes very important as soon as you become stronger and that you actually can get into those positions. And other people have looked at these exercises just to show that when you do something where you roll out on, this is called the ab slide or on torso track, and you can even use a ball, that this is actually quite a good way also of getting abdominal contraction, and you can use this isometrically, but you can also use it dynamically. And again, you get, especially with a sliding exercise where you roll out, you will get quite nice activation levels in your rectus, but you have to make sure that that in the obliques, this might just be a starting exercise, and then you turn people over, and then you increase the intensity. Because in the obliques, you will have a little less activity, and you probably, as soon as you become stronger, you want to increase that. So this is what I see in Denmark all the time. This is physio's favorite exercise. And I'm not saying there's anything wrong with the exercise, but they would do this for groin patients as well, and they say it's a stability exercise. But if you put EMG on, what will happen is that there would be almost no EMG activity, around 20% maybe in the front, and all of it will come from the hamstring and the glutes. So it's just, again, that we need to consider some of these exercises. Just because we think that it's our favorite exercise and we really like it and it might do some good, I'm not saying that, we still need to consider what we want out of the exercise. So challenge number 3 would be evaluating the effect. And I will give you an example, and that fits really nicely with a lot of the talks that's been here. So this is the best striker we have in Denmark at the moment. He had groin inguinal surgery with a famous hernia surgeon, And before going into surgery, the surgeon would say, this is going to take 4 weeks. Everyone was happy. And I'm quite sure, because I know the success rate I have is 95%. And he was back 1 year later, full return. So I guess he was one of the 5%. But that's what we see quite a lot. We see them get this inguinal surgery as well, and they tend to follow this program, but it doesn't fit, functionally, it doesn't fit with the 4 weeks rehab usually. And that might be that he had another entity as well. It's not, maybe the hernia surgery worked, but it wasn't the right surgery for the right problem. But again, one of the main problems here is that it's mainly the people doing the surgery or conducting the studies deciding when the return is and how the result is. So we actually looked in the literature to see whether there were any outcome scores that could actually look at this in a more objective way. So that would be the other thing we would put in our model. We need outcome measures here. And it's very important not to underestimate that patients can actually give a very precise history of how they're doing, and they're actually coming to you because they are no better. And I guess we often take this perspective, and sometimes we forget to ask the patients, but we tell them what we think the problem is. And that's why we developed this outcome score, and we did that in accordance with the COSMIN, which is a methodological way of doing it correctly. And you look at reliability, validity, and responsiveness, and you need all these areas to be sort of fulfilled in your outcome measure. And we did that in a clinical study. And that's the Hagers, as I showed you in the beginning. And it actually has 6 different subscales. So they're not related, but just to show that this is a way of measuring these problems. And what we saw is that especially the sports-specific problems and their ability to perform, these are problems and quality of life, these are the problems that these people are having. So if you just look at sort of more general things during the daily life, this is not as problematic. And pain in itself is not always a good indication of how these people are acting. You need to get questions related to sport, their ability to perform, or related to how they feel, how is their quality of life. And these people will always have, they are athletes, so if they can't perform, their quality of life is down. It's as simple as that. And we got that in the British Journal of Sports Medicine. And it's actually on a website, and Per mentioned this is in Arabic now. We're very close to that and very happy about that. It's in English as well, so we hope to integrate that into the Aspetar Groin Center projects. And again, just to look at the model here and say, this is the usual model. We've really emphasized this in any kind of study you want to do, exercise, surgery, whatever, and we really emphasize this to try and get an honest idea about this. Thank you.